Good afternoon, ladies and gentlemen. I will call to order the Tuesday, February 15th, the year 2022, House Insurance Subcommittee. Weather report, it is 66 degrees outside, and it is beautiful without a cloud in the sky. I just walked across from the Tennessee Tower, and I would encourage everyone, after you hear all of our business here, to go out and take a breath of fresh air. So, Ms. Adams, could you please call the roll?
Representative Sapicki? Hicks? Kumar?
Here.
Lafferty?
Here.
Mitchell?
Here.
Rudder?
Here.
Smith?
Here.
Terry?
Here.
Thompson?
Here.
Chairman Hawk?
I am here.
You have a quorum.
Thank you. The chair detects a quorum. Thank you so much. Any personal orders from any member on the committee? With that said, we have a calendar before us. We have item number 1 is House Bill 2655 that I will be presenting, so I'll hand the gavel off to Dr. Kumar.
Thank you, Mr. Chairman. Chairman Hawk, you're recognized on House Bill 2655. Motion. We have a motion and a second.
Thank you very much, Mr. Chairman and members. This bill, as you know, we dealt with the issue of a little pandemic over the last couple of years, and we have found something that's really worked in helping improve patient care, and that has been through telehealth. What this piece of legislation will do will remove the sunset from the current telehealth procedures and just allow telehealth to continue in the state of Tennessee. It's my understanding that all folks are on board, and I believe this keeps our patients and our medical providers in a good place. So with that brief explanation, Mr. Chairman and members.
Thank you, Chairman Hawk. Thank you for bringing this. Certainly, the pandemic was a devastating event of our times, but it did have some positive outcomes, and that was one to realize that telemedicine can be very helpful, facilitate patient care, make it more convenient, but at the same time avoid spread of infection, as well as having to sit in a doctor's office to read all magazines. With that, members, do we have any questions? I think everybody is very pleased about it. About questions been called without objection. We are voting on House Bill 2655. All those in favor, please say aye.
Aye.
Opposed? The bill moves on to full committee. Thank you.
Thank you, Mr. Chairman and members, so much. Chairman Kumar, I'm going to remember your words as I present the bill in your full committee, so thank you so much. I'm even let you present the bill next time. Item number 2 on our calendars today is House Bill 1843 by Chairman Terry. We have a motion on the legislation. We have a second. Chairman Terry, you are recognized on House Bill 1843.
Thank you, Chairman and committee. This bill, House Bill 1843, simply adds healthcare services to current telemedicine practices that allow audio only for behavioral health services currently in the state. CMS recognizes audio-only health services, and this bill would line Tennessee up with what CMS is currently recognizing. And with that, I believe there are some folks that may want to testify, or I stand ready to answer any questions.
Pardon me. Thank you. We do have several folks that do want to testify. I'm going to go to our committee members first to see if there's any questions at the onset of the sponsor of the legislation. Okay, seeing that. Forgive me. Chairman Hicks, you are recognized.
Thank you, Mr. Chairman. And Dr. Terry, could you just kind of walk us through an example of how this would be utilized?
Thank you. Great question. I'm going to give you a code and read out the code exactly what it is. A telephone evaluation and management service by a physician or other qualified health care professional who may report evaluation and management services provided to an established patient. So the key there is established patient, parent or guardian not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. And that's the lowest ones that they have out there for physicians, and it requires 5 to 10 minutes worth of medical discussion. And of course, you document your evaluation of them and your management that you did in order to meet that criteria. There's other codes that are greater than 10, between 10 and 20 minutes. There's other 20 to 30 minutes. An example that you may have of a patient that is currently under your care, maybe somebody that's got diabetes, and you follow them, they're established patient, and say they have, you're always concerned about diabetic foot ulcers, but say they step on something or they cut themselves, and they initiate the call to your office, and you during that time evaluate, what did you step on? Do you have a tetanus shot? What's your sugar been? What does it look like? So you're getting those questions from them, and at that point in time, your management may be, you say, well, I need you to come on into the office, and of course, if you come into the office, according to this code, you can't bill for that. But if your evaluation or management is maybe, I need to call you in an antibiotic, then that would be part of that process. So, and you could bill for that if they don't follow up and come into your office and have a conflicting code at that point in time. So that may be something that a patient could have. I'd say something from a personal standpoint that that has occurred. My mom, she's going to be 84 this month, followed by her physician, had COVID and had some issues. She had not seen him for that, so had not had a visit for that, but she had some issues with dehydration and confusion. And so she did not have audio video readily available to her, but we were able to get a conversation, get her evaluated, and a management taken for her at that point in time, and we did not have to go back in for something. So that's something that could have been generated, this code.
So let me give another example, another hypothetical. My 6-year-old, so let's say she starts showing symptoms, a cold, and so we call her pediatrician, and so we talk to a nurse. Obviously, a nurse calls us back. At that point, the nurse has probably reached out to the pediatrician, got guidance, and then they call us back and say, here's what the doctor says you should do. How does this legislation affect that, or does it at all?
That may be a great question when we go out of session, but from that perspective, again, a greater than 5-minute evaluation, you've generated it to the provider. The provider is speaking to you, doing the evaluation. You're the guardian, so this says that the guardian could do that, so you'd be the guardian that called. And if you meet that criteria, have been more than 5 minutes with them, and this first code's 5 to 10 minutes, then it could potentially generate that. If it doesn't meet that criteria, then it would not impact what you did. If the nurse just said, hey, this person's got, whatever, and you call something in, that wouldn't generate this code. And again, if you don't meet the criteria for this code, it's going to get rejected. And so understand that these aren't the high-paying codes or higher-paying office visit codes that are out there. And so if it gets denied and you haven't met these criteria, it's going to cost you more to go through that process and go through that denial than it is to meet all the criteria.
Thank you, Mr. Chairman.
And thank you. And I think we will get some more questions answered out of session. I do want to go down that road a little bit with you, Dr. Chair, if I could. I think I heard you mention within a 7-day time frame, within the previous 7 days. And I'll use the example of us traveling here to Nashville. We're back home on Friday, go for XYZ, and drive down here Monday, Tuesday. We get a consultation, a phone call back. Does that or does that not create a a second copay type situation, or if you're under the same code criterion, what does that do?
Great question. What you're asking there is essentially what's called a follow-up call, and that's something that we even do in the operating room or in the OR. We will follow up. How did your visit go? How are you doing? That's not something that would fall under this. What you're talking about, something that's generated by the office. That's not what this is. It would have to be something not related within the previous 7 days generated by the patient.
Okay, sounds good. I think that gets there. We do have several folks on the list who would like to testify and comment on this piece of legislation. I will read them off in order that I have them. We have Mark Sittig, who's a medical doctor with Tennessee Oncology. We have Julie Griffin with Tennessee Medical Association. We have Lacey Blair with the Tennessee Hospital Association and Joe Birchfield with Tennessee Hospital Association. I'll let you all duke it out who wants to fight to come up to the podium on that one. And we have Ben Sanders with Farm Bureau Insurance for Tennessee. So any questions at the moment? Without any, we will go into recess. And Dr. Sittig, if you are here, and forgive me if I've butchered your name, feel free to come to the table, and you can bring Julie with you there. I've just been informed that I did not wordsmith that properly. We are out of session, and we are in recess. So. Third time's a charm. We are out of session. Set the parameters for the group. We would like to keep testimony to 3 minutes, and we will have question and answer as long as we need to go after that. So, Dr. Sittig, you are recognized.
Thank you very much. Good afternoon. My name is Dr. Mark Sittig. I'm a board-certified radiation oncologist practicing with Tennessee Oncology. Our practice...
Sorry.
Quite the introduction. Our practice provides care for nearly half of cancer patients in the state of Tennessee across 34 clinic locations in both rural and urban settings. I'm also a member of the Tennessee Medical Association and a treasurer for the Tennessee Oncology Practice Society, a group representing community oncology physicians across the state. I appreciate the opportunity to speak to you today about the importance of audio-only telehealth visits for our patients. Like Dr. Kumar mentioned, there's been a lot of changes during the COVID-19 pandemic. One of the favorable ones in my clinical experience has been the implementation of telehealth, both audio-visual and audio-only. This has improved the continuity of care between myself and my patients. I'd like to share with the committee 2 cases that I think exemplify the importance of this particular issue. The first is a 92-year-old woman I had the pleasure of taking care of, Mrs. H., a lady with renal failure on dialysis, which is a 3-time-a-week operation if you're not familiar. She came to me with a newly diagnosed rectal cancer with symptoms and needed a short course of radiotherapy to palliate her symptoms. Following the completion of her treatment, I needed to follow up with her, but she lived approximately 50 miles away and relied on family members. Additionally, due to her medical comorbidities, skipping dialysis appointments in order to travel to me for follow-up visits, which could be conducted appropriately over the telephone, were not in her best interest. So I was able to follow up with her easily over the phone. She was able to give me thankfully, her lack of symptoms and her good response to treatment, and I was able to see her in person at a subsequent date and saved her time. The second case is Mr. M., a delightful gentleman, 66 years old, with a low-risk prostate cancer, which we follow with serial blood tests called PSA. He elected to pursue active surveillance instead of treatment. So as part of his treatment, we were following his blood values. As a small business owner, he frequently traveled about the state and required regular blood monitoring. In order to follow up over the telephone, I saved him time from coming into the office. We were able to appropriately evaluate his disease and make treatment recommendations while he was able to conduct his personal business. Audio-only telehealth is important in in comparison to audio video, because we know in our practice about half of patients do not have access to the video component of the technology. That may be due to lack of broadband access, lack of smartphone or iPad technology, or difficulty with these technologies. Additionally, a lot of my patients require time to travel, either from loved ones or taking public transportation. So audio-only telehealth is a great tool in our repertoire. I appreciate the opportunity to speak before you today, and would be happy to take any questions.
Thank you very much, Doctor. I appreciate that.
Ready for me?
Julie, Ms. Griffin, please, and forgive me, that sunshine's fried my brain a little bit. I'm a little off kilter today, so forgive me. Julie, Ms. Griffin, if you could please tell us who you are and who you're with, and begin your 3 minutes.
Julie Griffin, Tennessee Medical Association, and that's what happens when you work down here for 29 years. So there's just a few things that I want to mention, because there's been a lot of confusion around what types of encounters this entails. These encounters are only when the patient does not have access to the technology needed for the video component. It is not just any time a patient wants to pick up the phone and call for an encounter with their provider. They cannot have access to broadband. They don't have access to, luckily I have an iPad here, but they may not have that. There's people out there who can't afford the technology, the smartphones that are, $1,000 a pop. We want to create an environment where if it would have been appropriate to do it audio video, and it can be done at the same standard of care as it would be done if the video component was there, that's when we want to allow that patient that doesn't have access to have the audio component. In the instance in which Representative Hicks mentioned, I think one of the things that you mentioned is the nurse talks to the doctor, and then, well, the doctor has to come and conduct that 5 to 10 minutes. It cannot be relaying a message from a physician. It has to be medically necessary. You have to document in the charts that E&M code, as we call it, for evaluation and management code, has to be medically necessary and meet the requirements of what's medically necessary according to CMS and according to the insurer. If it doesn't rise to that level, it does not rise to the level of being able to bill. And so we're talking about a very small number of audio-only calls that we're going to be talking about. Maybe one of the supporters of this bill, and I probably shouldn't speak on their behalf, but the Disability Coalition. I've got a copy of an email from the Disability Coalition talking about the visually impaired, and they can't necessarily do the audio video. So this is what this bill is designed to help. We are not trying to do anything that's going to increase. Just when a doctor wants to just bill, that is not the intent. And I think the way the bill is drafted, it couldn't be done that way. We follow the CMS guidelines. We have to follow the rules of the payers. And I think that it's just something to add to those patients who are not as fortunate as I am to have the technology that I need, or not as fortunate that I can live in an area where the broadband service is available to them. And that's what we're trying to do. Thank you.
Thank you very much. Thank you both for staying within 3 minutes. I appreciate that. Any questions or comments for our presenters? Representative Smith, you're recognized.
Thank you, Chairman, and thank you, Dr. Siddig and Ms. Griffin. I just want to make sure that everyone understands in the current code, what you all are doing is essentially adding to, it's already a option when someone has behavioral health. This is just adding healthcare services, but it specifically says that when the video component is not available. So it's already in code that this is a default, not a preferred method. Is that correct?
Absolutely.
And if I could, Mr. Chairman, follow up. If you wouldn't mind, just to revisit that again about the charting, because I think that we want to make sure that not only is this not a preferred method rather than a default method, but also that people aren't taking the opportunity to code up a little bit. And I know the intricacies of that, and I know the arguments around that. I just want it read into the record for the purpose of legislative intent. Thank you, Mr. Chairman.
Go ahead.
That's a great question. Thank you. So in my practice, I utilize time-based billing for my telehealth encounters. So when I pick up the phone to answer a patient call because the patient originated the phone call, a timer is available on the same phone that is probably in your office, and it tells you how long you're on the phone call. I then have to go document that encounter for however many minutes that takes after we hang up the phone. And the same documentation process that would apply is if I just exited the clinic exam room and walked back to my office. So if there were an unscrupulous physician who were perhaps doing a number of these encounters in order to maximize some sort of charge, they would still be held to the same standard that we are in terms of the time that's required and the documentation that would be required in the medical record system.
And can I follow up? And it's not just putting in the record, I talked to the patient for 10 minutes. It's, I talked to the patient for 10 minutes. We talked about this. I gave this recommendation. This is the follow-up from that. I think we're going to have to follow up with more testing, whatever that is. It has to be documented, everything that was discussed in that encounter, to rise to the level of the documentation allowed for that 5 to 10 minute call, or 10 to 20 and such.
Thank you, Chairman. And this would, when you talk about tracking time, this would be very much applicable in the world of attorneys, whether they're riding down the road or whether you're face-to-face with them in their office, they're billing you for time. Would that be a fair comparison?
As a non-attorney, I think that would be fair. But just to reemphasize, it's not just the time element. As I imagine an attorney would have to demonstrate their work product that took that hour or 2 hours. Similarly, my clinical notes would reflect kind of a discussion that lasted 5 minutes or 10 minutes or 15 minutes and support that time code.
Thank you. Representative Thompson, you're recognized.
Thank you, Mr. Chairman. Ms. Griffin, you mentioned that this would be, if this bill's enacted, then it would be a rare or at least a seldomly used occurrence. What gives you the knowledge or to actually say that? Why do you believe that?
Do you want to answer that?
If I may, I could
Sure.
give you a clinical perspective. Approximately, I would say somewhere between 2 and 5% of my patients are eligible for telehealth follow-up visits at my discretion as a physician. This is because they're people that have a limited symptom burden, that do not have symptoms that would benefit from being seen face-to-face or for a physical exam. For patients that do have those issues, certainly in my discretion, I would not want them to be followed up over the telephone. And it would rely on the physician's good discretion that it was an appropriate audio-only encounter, again, when video wasn't available.
You got to remind me, what kind of a physician are you?
A radiation oncologist.
Okay. Okay, I would say probably a large percentage of your patients then in comparison with other specialists might be, you might have a larger percentage of patients in need of audio only.
Perhaps.
Services. Probably, okay. Okay. Then also in the example of the, I think you were answering Chairman Hicks on, talking about his child and having call and so talking about he calls, nurse answers, which is typical, and goes to the physician to ask the question, then comes back. What if the nurse, him or herself, would make a judgment call? Would that be also covered? I mean, it's a minor situation that typically an RN would handle.
The encounter has to be between the provider and the patient. It cannot be a staff member and the patient. So the instance Chairman Hicks mentioned, that a nurse calls back, they go and speak to a physician. The physician would have to call back themselves. They would have to do whatever the evaluation was. If they felt like that evaluation, of course, they're going to have to determine, does the patient have the video technology? That's got to be determined because the statute would say the video technology is unavailable. So they would have to not have the video technology. They would have to document the medical necessity for a 5 to 10 minute encounter or whatever that encounter entailed. And if there was a required follow-up to the office, if they said, no, we can't do it, we need you to come to the office, or you need to go elsewhere, that encounter, I'm correct in saying, that encounter would not be billed. It's only if the doctor can shore up the medical necessity and provide guidance to that patient to what needs to be done in that encounter.
Quick follow-up. An advanced practice nurse who works under the supervision of a physician, would that be considered a staff member in your scenario?
Advanced practice nurses can do telehealth visits now. They work under protocols and formularies by a physician, so they are allowed to diagnose and treat certain types of conditions. They can do follow-ups for physicians. I know in some of my recent episodes I've had advanced practice nurses follow up. None to the point of which I think would rise to the level of what we're talking about here today. I think most of the time, a physician would rather see that patient face-to-face. They don't, and I shouldn't say this with my physician sitting beside me, but I don't think they really love telehealth. But they know that if it helps the patient be more compliant, helps the patient get the care that they need because they don't have access, that's why they want to use it. That's why we're here today. That's why we put into when we're working with General Assembly and working with Chairman or Representative Smith, why we wanted to make sure that that patient had a relationship with that physician to even be able to call it telehealth. We didn't want the teledocs of the world, which I know some of the insurance companies use. I think even the Farm Bureau, I know it's going to test. They encourage their folks to use Teledoc, which is a telephone service. We don't want that kind of health care, particularly at the Tennessee Medical Association. We want continuity of care. We want to make sure that that patient is seeing a provider that has an understanding of their overall health, not just that episode. And that's why we're here today.
Thank you.
Thank you. Chairman Sapicki, you are recognized.
So we've already had a conversation. Would you agree with me that the best scenario for the doctor-patient relationship is face-to-face?
Yes.
And then second best would be telehealth, where you have a video and audio communication, right?
Yes.
And then now we're talking audio only, so that would be even further away from the best scenario.
With the exception of a patient who I would already know and would be able to predict what sort of clinical problems they may have, then audio only may be superior if it makes it more likely that I'm going to see that patient in a timely manner. If it means that their care would be delayed 2 or 3 weeks until a family member could drive them to clinic, for example, in that case, the audio only may be superior.
So excluding that example, just based off of quality of care, we all agree that we could provide the best care in face-to-face in the office scenarios the best, be able to touch, be able to see, be able to hear the patient. And then we're now, and I understand why telehealth came about, that we discounted the ability for a doctor to be able to touch their patient, and now it was just audio and visual. And now we're to the point right now where we're, in certain circumstances, allowing just audio evaluation. Do you feel confident that your diagnosis as a doctor could be the same as in person as versus audio only?
Yes, and if there was any question, I would have them come into my office. Or, for example, when patients call and they present with a number of new symptoms, if it's reaches a very low threshold that I'm concerned where they would benefit from an in-person evaluation, I always say, why don't you come in tomorrow first thing, and I'll see you at 8 a.m. I think physicians have been doing that forever, over the phone, after hours type of evaluations, or sending a patient to an emergency department or urgent care. And that same kind of thought process and mechanism would be at play. And I can only speak for myself, but all the physicians and I have the privilege of practicing with, we all do the same thing, which is if it's of any concern whatsoever, we get that person in. It's only for the very select patients that would be appropriate for this approach.
Because of the different levels of care, from in-person to telehealth to audio only, do you think it'd be fitting for a doctor, when they have that phone call, to issue a disclaimer to the patient, letting them know that this is audio only, I have limitations here, the best scenario would be to come in if possible, so that they know the level of care that you're able to provide?
It's a good question. I think when I arrange for these in my own practice, arranging for follow-up visits with patients, like the two examples I've provided, my general phrase that I tell every patient is, it's up to you. I'm happy to see you in clinic, or we can do this remotely. But I think based on your symptoms X, Y, and Z, or lack of symptoms, I think it would be appropriate. It's up to you. What is your preference?
So that sounds like a disclaimer.
Yes.
Thank you.
Thank you. Representative Mitchell, you are recognized.
Yeah, doctor. So if a patient, they've had surgery, or they're really sick and they're put in the hospital, are there different levels of care in a hospital setting, like intensive care? So there's different levels of care, correct?
Correct.
So in this scenario, the bottom line of it is the patient's getting some care. So in the situations that you deem appropriate, some care is better than no care at all, to make sure they're doing the appropriate things they need for recovery, or to, in your situation, to make certain that the cancer doesn't come back or spread even more. So some attention's better than no attention at all, correct?
Correct.
Thank you.
Thank you. Any other questions?
Can I say one thing?
Yes, and Ms. Griffin, before you go, I want to ask you a question as well. Talk to me a little bit about the term unavailable in the prior legislation in the code section. If you could talk to me about that and where we are with HIPAA rules and regulations, and how we essentially will define unavailable in this legislation.
We tried to draft this language with Representative Terry, Chairman Terry, in a way in which it was already currently in statute. If you all passed this same language last year as for the behavioral health, so we were trying to keep it in line with exactly what you all had already passed. That's the reason we suggested Chairman Terry drafted in that manner. I have asked the payers for assistance in if they needed more clarity as to what unavailable was. I have not gotten anything. I had a meeting with them, all of them, and They threw out their concerns, and I listened, and at the end of that conversation, every one of them heard me say, bring me the language that makes you comfortable. You know what I'm trying to get at. And I've not gotten anything back. So unavailable to us, in the way I interpret the statute, is that the patient has no availability to do this when it's necessary. It's not necessarily when the doctor's doesn't have the availability, because the doctor, if this is passed, the doctor will in order to do a telehealth visit, will still have to have the complete medical record. You can't do that on a golf course. I've actually heard that doctor might be on the golf course just making calls and billing for them. That's not what this bill would allow at all. It is in those rare circumstances where the patient themselves cannot get access to the requirements that it takes to have the audio-visual compartment. And I dare say that, save a few of you all, most of you all probably have some areas that don't have broadband access. We've got a broadband problem in a lot of parts of this state. You probably have individuals in your districts that do not have access to a smartphone where they could do the video. We are only talking about when that patient does not have access because the doctor cannot do it without being able to have the video capability and the access to the full medical record and has seen that patient previously. Does that answer your question?
It does. Ms. Griffin, you were going to say something else?
Yeah. To Representative Sapicki's comments, the way the statute reads, you cannot provide a telehealth visit, whether it would be audio only or audio video, unless you can provide the exact same standard of care as you would have provided if that patient was in your office. Now, it's always great to look face-to-face, and again, I've got a physician sitting beside me. My doctors always prefer face-to-face because they feel like the patient is more comfortable face-to-face. But again, if it's an audio-only encounter, that patient is going to have to see and hear everything they would have needed to see and hear, which is only hear when it's audio only, from that provider if that patient was sitting in that office across from that provider. So there's no difference in the standard of care, or it does not rise to the level of being able to be an audio-only telehealth encounter.
Dr. Kumar, you're recognized.
Thank you, Mr. Chairman. Certainly, face-to-face carries value. That's how we connect with a healthcare provider, and that is what we want. I asked a question to some of our insurance colleagues how I thought that people would prefer, and the telemedicine is really going to take off. And I was told that not really. Patients prefer seeing the doctor, and for that reason, it's not a big part of the practice. And all doctors lament is that face-to-face is what we are talking about, but these days there is a screen in between the two faces, between the doctor and the patient. But that's how medicine has progressed. Kindly tell me, what are the safeguards against overuse? Because it is just more convenient and do it quickly and so on, so that this method of having an office visit over the phone becomes more convenient and gets overused.
Thank you for the question. First of all, I think the utilization of this technology, as we've discussed, really only applies in select scenarios. I could not do much of my profession over the telephone. I need to evaluate patients. I need to physically examine them. I need to assess them for toxicities after treatment's complete. I can't do that with the majority of my patients through an audio-only encounter. So I, for my own practice, could never switch to a majority of telehealth follow-ups. Additionally, I think everybody that I know that enjoys practicing medicine in 2022 enjoys it because of the connection they have with their patients, and that is best facilitated especially at the consultation stage when you're just getting to meet someone for the first time via a face-to-face interaction. That also allows you the greatest opportunity to comprehensively examine them. So I don't think that in-person encounter is going anywhere. And I know many of my patients that do elect for telehealth follow-up intersperse those visits with in-clinic follow-up as well, which I think is probably a good balance for many folks that do elect to use telehealth follow-up.
And I would add to that, if that's okay, Mr. Chairman. These encounters will be subject to the utilization review by the payers, just like every other encounter is subject to utilization review. They have the ability to do audits of the product providers to make sure that they are documenting appropriately. And if those encounters are not documented to the level of which they have billed, they will recoup that money.
Sure.
So it's not to the benefit of a provider to be giving a lot of their time over to do this, only to have that time, that money taken away through recoupment.
Thank you. Just a follow-up, what would the billing mechanism be from a cost point of view, in the sense that currently office visits are coded as straightforward, low complexity, medium complexity, high complexity, but they are also correlate with time, how much time was spent. And here, I guess, would that make it not possible to have a high complexity or medium complexity visit, because those are 20, 30-minute time spans, and I don't see spending that much time on the phone.
I could probably count on two hands how many high complexity telehealth visits I've had. As you've mentioned, it takes a lot of time to reach that threshold. Most of those patients are not appropriate, in my opinion, for a telehealth audio-only encounter. They'd be patients I would see in clinic. Whether I see a patient in clinic or speak with them on the phone, my billing practice is through the 2021 E&M coding guidelines, which is by time. And so whether it's phone time or face-to-face and clinic time, plus the associated documentation, it's 6 of one, half dozen of the other for how I spend my day.
Thank you. Thank you, Mr. Chairman.
Thank you. Any further questions? All right, thank you all very much. We appreciate that. We will move on to our next presenter. Been informed that THA, the Tennessee Hospital Association, does not wish to speak on this particular issue, so we will move on to Mr. Ben Sanders. Mr. Sanders, if you'll please come up, find you a seat at the table. And Mr. Sanders, if you could please introduce yourself to us, tell you who you are and who you're with, and we'll start your 3 minutes.
Thank you, Mr. Chairman. I'm Benjamin Sanders with Farm Bureau Health Plans. Mr. Chairman, I appreciate the opportunity to address the committee. I also want to say I appreciate Chairman Terry and his time over the last week to discuss this bill and hear our concerns. At Farm Bureau, we write coverage for members in all 95 counties. We care deeply about the rural population. I would venture to say we cover more people in rural Tennessee than anyone else, and a lot of those areas don't have the broadband services that we're talking about. I don't know if I've ever been able to say this testifying, but I agree with everything that Julie and Dr. Sittig just said. Just keep that for the record, Julie. I would suggest the issue here with this legislation is not whether phone calls are an appropriate extension of medical practice. I would suggest the question is not whether doctors should or shouldn't get paid or how much they get paid or any of those things that we've heard about this bill over the last week. I suggest the issue is whether there is a discernible need of Tennesseans that's not being met that necessitates a new state law. Representative Smith, this might not be strategic to remind the committee, but a few years ago we opposed the telehealth legislation. I'm glad you remember. It's not because we opposed telehealth. By the time we were discussing it here, at Farm Bureau, we were offering robust telehealth and telemedicine coverage to all 95 counties. We opposed it because we believed that innovation and flexibility were what was needed in the telehealth space. And the reason I say that, Mr. Chairman, not to deviate from the point, is that the stated problem at that point was that providers, our provider friends, needed the assurance of a mandate in order to invest in that expensive equipment. I would submit that problem doesn't exist with audio-only phone calls. I say this as respectfully as I can. This seems like an excellent solution looking for a problem. Now, one step further, if unnecessary is one end of the spectrum, there's a lot of unintended consequences with legislation, especially when it gets into medical billing situations. Some of the questions that have been brought up, how does this affect billing and cost share and out-of-pocket? What does unavailable mean? Does that mean I don't have broadband? Does that mean I didn't pay for broadband? Does that mean I'm traveling and I don't have access? There's all these questions that I think would be better met in the private market and in negotiations with providers and insurers. The last thing I'll say, Mr. Chairman, is as a reminder, any law that mandates certain payment policies also restricts innovation. I would submit what we need in healthcare is more innovation and more flexibility that allows us to deliver more healthcare and reduce cost at the same time. Thank you for your time, and I'm happy to answer any questions.
Thank you very much. Questions for Mr. Sanders? Comments? Mr. Sanders, if I could, tell me a little bit about, we heard something about the CMS guidelines and the so I wrote my notes, the code criterion in the CPTs. Can you tell me a little bit about the functionality of that, and would that be affected by this legislation? Would it not be affected? If you could address that, please.
Sure thing. Yes, sir. Chairman Terry mentioned earlier that this would bring Tennessee in line with CMS. Now, I haven't seen any language. I've heard of a possible amendment that would limit this to CPT codes that CMS uses for audio only. I'm not sure if that's going to be a posture of the bill, but I've heard that. And so I'll kind of comment on all of that at one point, if that's okay, Chairman Hogg. CPT codes are billing codes for every medical procedure. I believe there are 10,000 CPT codes, a lot, published by the American Medical Association. CMS, Center for Medicaid and Medicare Services, they pick which of those CPT codes are covered by Medicare, and they set reimbursement rates for them. Over the last 2 years, CMS has published a number of variations of guidance on which of those CPT codes Medicare pays for telehealth. Their last guidance came out in January of this year. They identified 272 CPT codes that Medicare covers for telehealth. Now, out of those 272, don't hold me to that number, 89 of those they approve for audio-only telehealth. But I think it's notable, sir, that out of those 89, 86 of them are for behavioral health, mental illness, substance abuse, things of that nature. There are 3 codes that CMS currently pays for, and I believe this is what Chairman Terry was referring to, that pays for medical E&M evaluation and maintenance, if I'm not mistaken. I will note that CMS has designated those 3 CMS codes as only appropriate during the pandemic. They've identified 69 codes that are appropriate in a permanent basis for audio only, but they're all in the mental health, and I could get a list for you, substance abuse, that area. I would say those would already be covered by state law and the behavioral health statute that we have on the books. Does that help, Chairman, or did that just complicate things?
No, I think that did help.
Okay.
That did help. Representative Mitchell, you are recognized.
Yeah, thank you, Mr. Chairman. So let's go back to the argument of telehealth in the first place. So I'm remembering your testimony, and I'm pretty sure you agreed that telehealth would save money in the long run by patients doing what they needed to do, keeping patients out of the emergency room, keeping patients from being admitted or readmitted. It's kind of like the CMS code. You know, Medicare penalizes for readmission. So wouldn't the care, any type care, like my question, wouldn't some care be better than no care to keep these folks out of the emergency room, which is the most costly and the most costly to the insurer? Sure, it just makes good sense to do something that's holding down costs, would it not?
Yes, sir, Representative. I do agree with that. I think the second point, though, to that is that not happening today? Everyone I've had a conversation with about this bill talks about the conversations that they've had with their provider. My doctor calls me on the phone, and he has for 10 years. I don't think this would change his practice on following up with patients. So I completely agree with you. More care is always better. It's the discernible need and the lack of care that we haven't seen evidence of. We haven't had any of our members tell us that they're not able to talk to their doctor on the phone, for example.
And you know, and going back to the codes, you know, there's many codes. Usually CMS is about 3 years to 4 years in front of the states. You know, finally, you know, CMS will approve a code, and you know, the lobby fights and fights and fights in states until they finally, you know, see the handwriting on the wall, and this is gonna go forward. So they agree, hey, let's include this in the coverage as well. You know, why don't we one time be on the front end of something and try to reduce cost on the front end instead of being forced to do it? Let's do something. It's kind of like the telehealth. We knew it was going to save money. We knew it was going to improve care, but we still had to fight tooth and nail to get it in this state. Let's just do something that gets care to the patients. Like I said, whether it's just some care. It may not be to the extent of care we would like with a video conference or an in-person visit, but just making sure that patient is on the right track, that keeps them out of the emergency room and keeps the readmittance down.
Would you like a comment, Representative? Okay, yes, sir. That's an excellent point. I would suggest that there are two issues there. One is coverage of certain procedures, if I can use audio only as a procedure. And the second is a payment methodology. And so a phone call that is paid the same as in-office, while it might be good medical practice, it doesn't reduce cost in our book. The reason that we oppose the telehealth legislation to start with, now that's water under the bridge, obviously, is because we wanted to see innovative models that did both instead of increasing care at the same cost. And of course, there's the argument, as you well make, sir, about more care reduces cost in the long run. That's why we contract with Teledoc at Farm Bureau, and we have for years, because we see cost savings in other medical areas by people avoiding ER visits and critical care visits and that kind of thing. So those two issues to us are separate. The way this is written in the current statute puts those two together.
Dr. Kubar, you're recognized.
Well, thank you. Thank you. You bring valuable insight to it all. CPT codes, which is current procedural terminology, go everywhere from a simple visit for a cold to the doctor's office to cardiac or neurosurgery. So everything is all encompassing. Okay. The mental health codes, 86 or so that you mentioned, and then 3 codes that are suitable or covered by CMS for telehealth. Those 3 codes, my thinking is, would be most likely office visits, because that's what you're going to do on a phone call or a video encounter. And so a visit of a small matter or low complexity over the phone can be handled, but the diagnosis for that visit, for that CPT code, diagnosis can vary anywhere from codes to various aches and pains, arthritis, blood pressure, diabetes management, right? So it can cover a wide variety of situations for patient care, although codes are only 3.
I think I follow, sir. I will say medical billing is not my thing.
Right.
So you might have just gone over my head, Dr.
But
Kumar.
I think when you say there are only 3 codes but covered by CMS for this telephone or video telemedicine, that means that it's very limited in scope that CMS covers. But it's not limited. Only the visits are done, but the scope of those visits with diagnosis, they can be very, very wide.
So they could have additional ones, is what you're saying. Additional codes.
No, codes can stay the same if it's an office visit or a telehealth visit of low complexity, right? That can mean a cold, that can mean a sprain, that can mean just simply blood pressure or medication adjustment, that can mean variations in blood sugar. So those are the diagnosis codes, but the procedure code for billing for an office visit stays the same. It's a matter of low complexity. Am I?
Okay.
I just wanted to clarify that the fact that only 3 codes are CPT codes are covered for this does not mean it's of limited use. The use can be very, very wide because diagnosis can vary, but the amount of time and effort involved in diagnosing and treating over the phone of a low complexity situation stays the same.
Yes, sir.
That's the point I was making.
Fair point.
But it just came across that it's a very, very limited scope, but it's not. The codes are limited for procedures, but diagnosis codes are numerous.
That's an excellent point, sir. And I didn't mean to insinuate that it was a simple issue, by no means. The CMS codes, when it deals with telehealth, are much more robust. Those are the only 3 for audio only, is my point on that.
True. I just wanted to clarify for all of us, and it helps me to think it out loud. Thank you.
Yes, sir.
Thank you, Mr. Chairman.
Thank you, Chairman Kumar. Representative Smith, you are recognized.
Thank you, Chairman, and thank you, Mr. Sanders. We're not fighting today, unlike the years past. Just one thing I want to make sure for the record is that based on current law that we have, plus this amendment or this bill that is likely to pass, is there anything that prevents the insurance companies from reviewing the medical record, seeing that maybe a doctor inadequately records that that level of care wasn't delivered? There's nothing that makes this an automatic payment. There's still that back and forth of making sure there's a requirement for documentation in the medical record. Is that a fair statement?
Yes, all of those would still be governed under the provider contract that we have with them. You're correct.
And just as a follow-up, that's not unusual. And the reason I'm making this comment is we're not really doing anything unusual. It's just that as more and more technology allows people to be cared for in a home-based environment, they're able to watch their heart rate. They're able to do their own blood pressure. They're able to do their own blood sugar. A lot of this is done, but they do have to have some sort of professional oversight. So whether it's remote patient monitoring or in the case of the radiology oncologist who was trying to save a renal dialysis patient from missing one of their sessions, I think that we can all agree that there will not be payment unless the medical record establishes that certain level of care is recorded that matches the CPT code that will trigger the payment.
That's correct, Representative Smith.
Awesome.
Yes.
And that's why I'll be voting for the bill. Thank you.
Yeah. To elaborate on that, all of those safeguards that we have in place now would still be in place under this. I will note this statute would take away any flexibility to work on additional payment methodologies because it requires not just that we cover, even with those safeguards, it requires how we have to cover them, which is, as I mentioned earlier, a separate matter as well. But your premise is correct. Yes, ma'am.
All right, thank you very much. Seeing no further questions or comments from committee members, Mr. Sanders, thank you so much for your time. I'm going to see if I can get this correct as we go back into session. All right, I got that right. Chairman Dr. Terry, you're recognized for any closing comments on your piece of legislation or any questions from any members.
Thank you, Chairman and Committee. Great discussion here. Appreciate all that. I did want to point out for the members of the committee, currently there are codes that are for established patients that are levels of service that you can do. One of the codes being 99211. And with that, you have to meet 2 of 3 criteria, and this is what, is going to go into the chart. And 2 of those 3 criteria, the history, exam, and the medical decision-making. It's an or. It doesn't have to be an exam. And so in those levels, you can do it without a physical exam on that patient. You are getting that history. You are making a medical decision. And so that's already established for inpatient visits. This is, again, for an established patient. They have those codes, the 3 codes that they mentioned. I would like to point out that CMS is in the process of making those codes permanent. And in the event that they did not, it's my understanding that those, if visits after this bill hopefully gets passed, if those codes go away or if they change or something along those lines, if they go away, it could be denied at that point in time. And so from a physician standpoint, again, you're going to be documenting those. And if it's denied because there's no longer a code available, then we will be looking at something else. And as one of the other our colleagues had mentioned, we're getting ahead of the game and we're working as they are working at the federal level to make these permanent. So with that, I renew my motion.
Thank you for the depth of conversation. I think we are ready to vote on the legislation. Ladies and gentlemen, we are voting on House Bill 1843. All those in favor of House Bill 1843, please signify by saying aye. Aye. Anyone opposed, please signify by saying no. Your bill moves forward, Dr. Terry. House Bill 1843 moves forward to full insurance committee. Seeing no further business to come before this subcommittee, we are adjourned.